lack of time, we'll move on to the next speaker, Dr. Anagha. The secure choice for astigmatism correction, Dr. Anagha. Thank you, Dr. Ashul.
Very good morning to one and all. Thank you so much. So, no financial interest in any of the products mentioned. So, when we plan to do a toric IOL, what do we look at? First is complete astigmatic correction. So, you should have a good stability of the lens rotational wise. You need a good optical clarity, which gives you good contrast sensitivity. You should have a good ease of implantation because you're going to plan it in different kinds of settings. It should be a perfect platform with years of trusted technology. And post-operatively, it should continue to give optical clarity and reduced chances of PCO. So let's look at a few cases. So this is an intumescent cataract with a very high chance of a radial extension of the CCC. I'm planning to do a spiral CCC, and we are doing a premium toric IOL for this patient. So whenever you plan a toric IOL, in such cases, you need to have a very, very easy and good implantation of the lens. So here we are putting in viscoelastic into the infusion port, and once the IOL is put, we remember to remove the OVD from behind the lens, because if the OVD remains, that is a very high chance of rotation of the lens, and then you align it along the axis which is desired. I'm using the Varion system here, which is the markerless system. Now, a second case, a very high myopia patient who has already been operated for an IPCL many years ago, comes back with a cataract. So you have a double challenge. Now, this is a 2.8 millimeter incision. This is a care group IPCL. So with a hand over hand technique, I am removing the IPCL first. And then you can see the anterior subcapsular cataract there. A capsulotomy has been done. And we are putting in the IOL. It's a very high myope lens, longer axial length, remember, so you need to have a good rotational stability for this lens, again aligning it onto the desired axis. Third case, again a challenging case with a smaller size pupil. I'm using a B-hex ring, but look at the ease with which the IOL goes into the capsular bag in spite of the B-hex being there, and can be easily rotated and implanted, and the B-hex is removed. So what is common in all these cases? The commonality here is the lens, which gives us the astigmatic correction to its complete extent and a good rotational stability. So let's evaluate it. First thing is you need to have a perfect biometry. See that you have a good optical surface, ocular surface, you get perfect K readings. Use the PCA. The posterior corneal astigmatism has to be considered, and you need to have special features on the lens, like you have textured rough haptic surface. This is the Hoya lens, which has the toricity on the posterior surface and an asphericity on the anterior surface, and you get from T2 to T9. The important thing is you have a multi-cert preloaded technology, so you can see here the injector knob as well as the plunger. So if you are using a single-handed technique, you can use or a bind-handed technique, and goes in very easily through a 2.2 millimeter incision. So if you look at the rotational stability, these were 103 eyes which were evaluated at 1 hour, 1 week, 1 month, and 6 months, and you can see a rotation of just 1.1 degrees at the end of 6 months. We have a lot of options available today, so when you compared it with the other lenses, you found that none of these lenses rotated more than 5 degrees. And in a longer axial length eyes where you feel that there could be probable rotation, 100% of these eyes had less than 10-degree rotation. And again, comparison with other lenses for the decentration as well as for the tilt, you can see that the decentration is absolutely negligible. These are our first 100 eyes that we had evaluated, and the post-op residual astigmatism, 98% were within 5 degrees at 6 months. Why do they not rotate? Okay, one is because of the textured rough haptics. So they grip onto the capsular surface at the edge of the capsular bag. Also, they avoid optic sticking when it is folded. And the optic edge is also textured, so it reduces dysphotopsia in these patients. As regards clarity of vision, there is least PCO rates because of the ozone surface modification. So how does this happen is they are treated on the surface with UV ozone. This causes greater adhesion of the lens to the capsule and to the surface, and this increases the sticking of the IOL to the surface, reduced PCO rates also. Few additional features, just in case there is a slight amount of decentration, the amount of coma that is induced is negligible because of the off-axis alignment, and no glistenings compared to the other lenses that are available. So you continue to have greater clarity. Plus you have benefits of a good preloaded injection system. So if you noticed in all those lenses there, it gives you very quick implantation as well as eliminates the need for post-operative cleaning, sterilization. There is no chance of mishandling or misloading of the IOL and saves time in the operating room. So basically greater efficiency, predictability as well as safety. Most importantly, I've been using this Vivinex platform for the last so many years, not just for the torics, but even for the other monofocal lenses. So whether it's a 10 diopter lens or a 30 diopter lens, if you compare the amount of resistance force that is used to deliver the lens in the push mode, no matter what the diopter, it goes in with equal ease. So in all, all you need for best toric outcomes is a perfect biometry, a meticulous surgery, good rotational stability of the lens, and for good clarity, you need a good material as well as a good preloaded injector system that helps to give the greater ease of implantation. So thank you so much. All in all, to get better visual outcomes, a very humble request for your support. I'd be standing for member scientific committee in the ensuing AIL elections. Thank you so much for your kind attention.
Thank you, Dr. Anagha. Any questions for Dr. Anagha?
Definitely more thick, but sir, if you compare this, the amount of resistance that you would need to go is as good as a 10 diopter lens. You will never know the difference, and it goes in through a 2.2. If you have used above plus 30 plus lenses earlier, you would have realized that you need a MDCL cartridge, and the amount of pressure is also more. So that is a very important difference.
In your HMSC case, that capsule was very nicely stained. Do you use any different technique to use the entire capsule?
No, sir. I make it a point to keep it for 1 minute.
1 minute.
Yeah.
Same dye?
Same dye.
Okay.
Same dye.
Thank you.
Thank you so much.